afternoon. We at Kaiser Permanente are very proud of the Bay Area Council and very happy to be part of the Bay Area Council functioning. When you look back into history, the very first convening meeting for the Bay Area Council took place in the Kaiser Permanente boardroom, and the convener of that group was Henry Kaiser, and he believed that the Bay Area needed a setting and a group where the business leaders of the Bay Area could get together and work in harmony to resolve issues and make the community a better community. And he was one of the founding members. I don't believe he was the first chair, but I think he was the convener. And we have been a very happy member of the Bay Area Council ever since. The Bay Area Council does great work. They are a very enlightened, progressive, cooperative, collaborative organization. And I think the kinds of themes that you're seeing at the meeting today represent the long-term history and theme of the Bay Area Council very well. The council does good work, and it continues to do good work. So we're happy to be part of that legacy and part of that tradition. But I'm going to talk about healthcare costs. I'm going to talk about healthcare delivery and healthcare functionality. Healthcare costs way too much money. Healthcare consumes 18% of the GDP of this country. No other country in the world comes close. We are spending $2.8 trillion on healthcare in this country. If you took the healthcare economy of this country and compared it on the world stage, it actually is the 5th largest economy in the world. It's bigger than almost all the other countries in the world. We spend enough money on healthcare. We need to figure out how to spend healthcare dollars better, more wisely, more efficiently, more effectively, and we need to create a more affordable healthcare delivery system for this country. We need to do a much better job than we've done. When you look for an inspiration, the food industry of this country used to consume 40% of the family budget, and it used to consume 30% of the workforce. So food was 40% of the budget, 30% of the workforce. Food is now under 10% of the budget, and it consumes less than 2% of the workforce. We didn't make that progress in food by rationing food. We made that progress by re-engineering the production of food and re-engineering the distribution of food, and in the process we ended up with better, safer, more affordable food. We need to do the same thing in healthcare. We need to re-engineer the delivery of health care so that we end up with better, safer, and more affordable health care, and it's entirely possible to do that. We are on the cusp of a time of change, significant time of change for health care, because the new toolkits that are evolving in health care are so good and so capable that we can use the new toolkits to accomplish an industrial revolution in healthcare that's going to be transformational. We are in the edge of a golden age for care delivery, an evolutionary time where we can make care better, safer, more accountable, and more affordable, and do it by changing the way we basically distribute and produce care. Now, how do we do that? For starters, we need to focus. We need to recognize the fact that care costs are not distributed evenly across the entire population. 1% of the population is about 30% of the cost of care, 5% is about 50%, 10% is about 70% of the cost of care. So a small number of people use most of the care dollars, and those people present the biggest opportunity to us. And when you look at who those people are, it's actually not people with cancer, cuts, colds, it's people with chronic conditions. 75% of the cost of care come from people with chronic conditions, and we get chronic conditions care right in this country barely half the time, and 80% of the cost of care come from people with chronic conditions and comorbidities. And we do a very, very weak job in this country of having doctors connect with each other and deliver care collaboratively for patients that they mutually serve. We don't have the mechanisms to do that work, and we need the mechanisms to do that work because team care is far, far, far better than care that's done in silos by solo people who are unconnected with each other. We've cut the number of broken bones in our seniors by over 40%. We've cut the HIV death rate for our HIV patients to less than half of the national average by delivering connected, coordinated team care for those patients using a new toolkit of care and making sure that there's an interaction with the patient at a level that's different than just the traditional fee-for-service interaction with the patient. So there's great opportunity ahead. We can do a much better job of taking care of patients if we actually focus on the needs of the patients and deliver the best science and the best toolkit for care. And when we look at the opportunities in front of us, what we can see is that care delivery is evolving relative to the site of delivery. Now, traditionally, there's been two sites of care delivery. And one site has been the hospital, and the other has been the clinic, or the clinic equivalent. And we're seeing, with the new toolkit available for care, an evolution from those two sites. So those two sites are still going to be incredibly important to us, and they both need to be really well supported. So the hospital is the first site of care, and we need to make sure hospitals are safe, that they are efficient, that they have all the information about the patients, that the patient's total care needs are identified and met by the hospital, and that the hospitals have the best equipment so they can do the right scans and the right imaging and the right everything. And we need to pay half as much as we pay now for imaging, but we need to have all of the right imaging and all of the right equipment in the hospital. So the first site of care will continue to be the hospital. We need to do that continuously in improving ways, and we need to bring down the cost of that care. Second site of care is going to continue to be the clinics, the office, the medical office, the doc in the box, whatever setting that you have, face-to-face encounter with a patient, and that will continue to be an important site of care. The third site of care, and this is happening relatively quickly, and it makes a huge amount of sense, the third site of care is going to be the home. The new medical technology is, and the connectivity tools are so good that it is now possible to deliver a lot of care in the home that couldn't be delivered in the home a short while ago, to monitor patients, track patients. It's possible to get an EKG in your kitchen and to get it from a piece of equipment that costs $40. The technology is changing so rapidly that the ability to deliver care in the home is going to be incredibly important. And we should be able to cut the number of heart attacks. We should be able to cut the number of complications in diabetics. We should be able to improve the quality of care for all of those patients in the targeted populations in a significant way by delivering the right care into those patients in their homes in a coordinated way. The fourth site of care is a really fascinating one, and the fourth site of care is going to be the internet. The world is now becoming very flat relative to medical care. It's now possible to get diagnoses on the internet. It's possible to coordinate care. It's possible to do follow-up care. It's possible to have an entire infrastructure of care delivered electronically and virtually. And the ability of that functionality is going to transform care delivery. We need to make sure that that doesn't create a new set of electronic silos where the information is just as separate and just as uncoordinated and just as dysfunctional as the traditional physical silos. That what we really need is use that toolkit, but use it in a way that's focused on the patient, where you have all of the information about the patient all of the time, and you've got the right care and the right care settings and the right care follow-up. And so we need to be using the internet as a site of care, and we need to do it in a really effective and efficient way. So when you look at Kaiser Permanente, what are we doing relative to pursuing those four sites of care? We're running hospitals. Our hospitals are now probably the safest in the country. We're doing some really good things in hospital care. We've got our traditional care sites with all of our clinics and our medical groups, and we're doing Great work there. We're reaching out into doing home-based care in a number of areas, and we're using electronic toolkits to support our doctors. So we have electronic medical information for all of our patients all of the time. Now, one of our basic underlying driving guidelines at Kaiser Permanente is to make the right thing easy to do. That's the guideline for the doctor and the patient. Make the right thing easy to do. If you make the right thing easy to do, it's a lot more likely to happen. And if the right thing isn't easy to do, it's unlikely to happen. And if the wrong thing is easy to do, the wrong thing happens. So you just have to figure out. And there's two parts. The first part is to figure out the right thing. And the second is to do the ergonomics necessary to make it easy to do. So the electronic medical record lets us give the doctors all of the information about all the patients all the time. We also have the world's most complete electronic medical library. Every textbook, every journal article, 2,500 care protocols so that our doctors in real time can get all the information about their patients. Every doctor in America needs a toolkit like that. There are 80,000 medical journals. Doctors just can't keep up. There's no reason that every doctor in America shouldn't have a similar toolkit. So we need electronic toolkits. We need follow-up. We're doing e-visits. Right now with our patients, we do about 1 million e-visits a month. We do 81,000 times a day. We send out lab results electronically to patients on the internet. We have iPhone apps and Android apps that let patients look at their own medical record anytime they want to. They can schedule appointments. They can email their physician. They can order drug refills. And those are all happening to scale. Patients are using those by the millions. We have a huge amount of use. That app got 2 million uses the first month we put it out. So patients want to go here. This is the right path to be on. If all of healthcare went down this path, we could reduce the cost of care for the country, and if everybody went down this path and had coordinated care for their patients and focused on the patients with the chronic conditions and comorbidities and made sure that the doctors for those patients had information shared about those patients, and if the patients have the information that they need about their own care, that's the right direction for the country to go. And we need to go down that direction, and we need to have the country improve both the quality of care and the cost of care. And I'll conclude by saying there's a reason that we need to do that. Partly we need to do it because we can, but partly we need to do it because the alternative to fixing care and using this toolkit in appropriate ways and changing the business model of care so that we can use this toolkit and end up with lower cost care, the alternative to that is to continue to borrow money from the future to pay for care costs today. And when we borrow money from the future to pay for care costs today, what we're doing is we're passing that debt onto our kids and our grandkids. And when their dollars, when their incomes are taxed, the first use of the money that's going to come out of their tax is not going to be streets and bridges and schools and their local police departments. The first use of that money is going to be to pay back the debt that we are incurring today because we are not responsible enough to bring healthcare costs down to reasonable levels so we don't have to pay for it with debt. And that's, I think, unconscionable. I think what we need to do is take the responsibility collectively of getting the costs right today so we don't kick those costs down the road to the future so they're paid for by our kids. So I think I'm actually an optimist. I think we have a marvelous opportunity right now to do some really remarkable things relative to care delivery. I think we can make care better. I think we can make care outcomes better. I think we can make it more convenient. And I think to do that, and this is the perfect place to center that because Silicon Valley is going to be the heart of a lot of the innovation that's going to be transformational for care delivery. So with that, I thank you very much. Be well.
George, you said the U.S. needs to do a better job in delivering health care. Who exactly has to do a better job? Is it the government? Is it the private sector? Is it the plans?
I think it needs to start with the payers, including Medicare. Medicare needs to stop buying care by the piece and start buying care by the package because you can't re-engineer a piece. If you're trying to do re-engineering and basic redesign of processes and your reimbursement model is a bunch of fees, every time you re-engineer something, you take out a fee and you lose money. And so asthma care, we could do a much, much better job of asthma care if you pay for an entire package of care. And if you pay for each piece, then the emergency room makes a lot of money, and the follow-up doctor makes a lot of money, and there's no coordination of the care. If Medicare and Medicaid both paid for care by the package and not by the piece, the entire care delivery system would re-engineer very quickly and start delivering care by the package.
Medicare, Medicaid alone, or do you think fee-for-service should be eliminated?
I think fee-for-service needs to be drastically changed. I think it may need to be eliminated. I mean, I talked about the fact that we've cut the death rate for our HIV patients to half the national average. We do 14 things for those patients that do not show up on a Medicare fee schedule. So if we just did what Medicare paid for on a fee schedule, we would have twice as many of our HIV patients dead.
Let me take it up 30,000 feet for a second. U.S. has been chasing health care reform for more than 100 years, since Teddy Roosevelt and the progressives, talked about the cost of health care. We've been chasing one thing, cost. And everything the government has done and tried over the last 100 years in this area to reform or expand coverage has not bent the cost curve. We've had a march on costs. Do you see anything in the federal health care reform law that is going to bend the cost curve?
Well, the reason we haven't changed the cost curve is because we continue to pay on a fee-for-service basis. And actually, when you pay on a fee basis, a hospital infection is a chance to make a lot of money. There were 1.7 million patients last year went to hospitals in this country and got an infection they did not have the day they went to the hospital. That's 1.7 million patients got an infection, and those infections doubled the revenue for the hospitals. Now, if you think about that, if the automobile industry in this country, every time a car crashed, somebody bought 2 more cars and paid full price, what would the safety focus be in the car industry?
Okay. Good point. So I serve on the Health Benefit Exchange in California, which is the body that is in charge of creating the marketplace for individuals and small businesses and healthcare reform. Is there something that you think that people like me should be doing in order to be able to effectuate that? I'm sure you'd like to tell me.
Yes, I think the exchange should set rules that basically require that the participants in the exchange do team care, coordinated care, that patients have the ability to get, that the product models aren't based on cost avoidance and deductibles and getting away from paying for care, but they're based on delivering the right models of care in the right way. And I think there needs to be a lot of transparency about the care delivery model.
So your model of care is actually, the integrated service model is touted as the future of medicine in the U.S., and it's been used as the model in part for the federal law. My colleague on the commission actually called Kaiser's model accountable care organizations on steroids.
Right.
How would you grade yourself in terms of cost efficiency? Are you as cost efficient as you could be? Why aren't your costs lower?
We actually have, good question. We have a cost trend that's lower than the industry, typically by a couple %. Our costs, if you look at the individual marketplace, if you look at the small group marketplace where we all have about the same product, we tend to be 10 to 20% lower than the other small group products.
Is that the best we can do?
So that's as well as we need to do now.
But wait a minute, wait. You just finished lecturing us on what we have to do, and we're all with you in terms of how urgently this is needed, and we're all putting you on a pedestal because we believe your model is actually the place we need to go.
Right.
What are you doing right, and where's the evidence that it's gonna deliver the cost-effective, affordable care? And what's the empirical evidence to that?
If everybody in the country was running at our numbers, instead of $2.8 trillion in care, it would be about 2.4, 2.3 trillion, which would be quite a lot, and in a lower trend. We're running low single-digit cost trends, and everybody else is running high single-digit or double-digit cost trends. And we have fewer people with heart attacks. We have fewer people losing kidneys. We have fewer people with broken bones. We actually are delivering a higher quality total product which is a good use of money. I mean, we're spending the money, we're using the money that we collect to make sure that our patients get the right care, and we're getting better outcomes.
So,
Did you see the Medicare 5-star?
I'm sorry?
Did you see the Medicare? Medicare just rated all the health plans in the country on 53 quality criteria, and they rated 459 plans, and they only gave 9 plans of the 459 5 stars. Okay, 5 Kaiser Permanente regions were there, and our lowest score was 4.5 on quality. So when you're looking at quality, we had the highest quality in the country by far on 53 measurements, and we had lower price. So lower price and better care is pretty good value.
The U.S., though, spends twice as much as our nearest peer, I think,
Yes.
in developed countries. Do we have the best healthcare system in the world, even if it's twice as expensive? Who does?
No. Actually, Europe doesn't have a much better system. They just have much lower prices. But the Netherlands, same-day care in the U.S., only 40% of patients in this country get same-day care. In the Netherlands, it's 70%. The percentage of same-day care in Switzerland is much higher than the U.S. France is better. I mean, most of the European countries have more hospital care than we do. They have more medical care. They do everything at a greater degree than we do, except for scans. We have more scans than anyone except Japan. But everyone else is actually delivering more care with generically better outcomes than the U.S. Having said that, France, Netherlands, Norway, Denmark. I'm meeting next week with all the Minister of Health and all of their staff from Denmark, and they're studying us and trying to figure out how they can take their care system and be more like Kaiser Permanente. Minister of Health in the Netherlands just said the Netherlands would be improved hugely if their care system looked like Kaiser Permanente. So the other countries are looking to us, and because they're all collecting the data, but we're the only ones using it. They've all got electronic medical records, but we're the only ones using it to deliver and improve care. So the ministers of health in Europe are looking at us right now as a model for the world. In fact, I'm keynoting the HIMSS conference of Europe before I do that, and they're spending the morning talking about Kaiser Permanente use of data to improve care.
You've been you've been a pioneer in electronic medical records. You've been using it for more than a decade, I think.
Yeah.
Why haven't we made more progress in this country on electronic medical records, and what role do you think that will play in the delivery of the healthcare system of the future?
That's a really good question. I think it'll have a huge impact, and I think one of the smartest things in the recovery package, one of the really smart things, was to fund electronic medical records across the country. I think we're beginning to put an infrastructure in place. It was as smart as building railroad tracks across the country. I mean, it really will now give us the ability to go the next step. And one of the reasons I mentioned earlier I was optimistic is because now that care providers all over the country are putting their data on the computer, we can start using that data. And 5 years ago, it wasn't there, so we couldn't use it. But next year, over 2/3 of the care sites in the country will have electronic data. And once they have it, we can start using it to transform care.
Great. Well, thank you very, very much for your talk, and for, don't forget the book. I think they're for sale. Healthcare, not reform itself.
And all the proceeds go to the community clinics of Oakland. So it's
Great. Thank you very much.